tech savvy.
No issues.
I don't know exactly what is the problem. It's coming the same way. Like
No.
actually 24 hours.
I just, we are online now.
You're online? No.
Yeah, it says like, thank you.
Is it projected already? You're waiting for the faculty.
Yeah, can you see me? Am I online? No.
Dr. Anand, I can't see you.
Okay, one moment, please.
You need to turn on the video.
Should I share the screen? Start video, okay. I'm sorry.
Hi, Dr. Anand, how are you?
I'm fine, thank you. How are you?
Yeah, I'm good, thank you. This is Dr. Srinivas. He is a senior orthopedic surgeon from Vijayawada.
Okay.
So he is also one of the panelists. And Dr. Ashok Shyam, he is helping us to get it connected to Ortho TV.
Okay.
Hi.
Nice meeting you all.
Yeah, we are online already. You can go ahead. So we have about,
So shall we go ahead?
You can go ahead.
So how does
Okay.
it go? So I'll share the screen. That's it.
Okay,
Right?
so so we are on the third talk of learning basic arthroscopy. So we have the radiography of the knee in sports medicine. So it's a very narrow talk. So we will have a better understanding here. If you're already online, you can go ahead with sharing the screen.
Where can we check for the questions?
I have sent you the link, sir.
Okay, I'll take a look. Yeah, I've got it.
Hi, good afternoon all. Am I audible?
Yes, you're clear.
Yeah. So so we can go ahead.
Yeah.
Yeah. So we have the overview of the topic would be anatomy, radiographic views, and we have quite some rapid checklists that we have to go through while assessing the radiograph. And yeah, few slides about stress imaging, common pathologies, few slides on patellofemoral dysplasias and post ACL, PCL reconstruction imaging. So we are basically dealing with radiographic imaging here. In sense like mostly will be plain radiographs. I understand that things have drastically moved and we don't pretty much use radiographs for detailed imaging. It's been replaced by multiplanar imaging like CTs and MRI. But still, the basic pre and post-operative imaging and rapid assessment is all done by radiographs. So we'll start ahead. Yeah, so we have this illustrative diagrams, few of them, which we can see the tibial condyles. The gray area is the articular cartilage, the tibial condyles, the femoral condyles, the patella, and the overview illustrated as if it's projected on the frontal projection. Then we have our further illustration where it starts with the ligaments which has been illustrated here, like the medial and lateral collateral ligaments and cruciate ligaments. So that's a lateral illustrative diagram. Usually this is depicted as if it's been taken on a horizontal projection, where we assess mostly the suprapatellar rhesus, the patellar tendon, and the joint space as well. So most of the imaging basis, especially on radiograph, is very crucial in positioning. Remove this. Sorry. Yeah, so the tibial parietus, which are seen, should be really sharp, and the cortical line should be defined when we see an adequate and optimal radiograph. The femoral condyles, yeah, of course, we can't see 100% superimposed condyles as they are asymmetrical, but some degree of rotation will always be there. The inferior bord of condyles should be equidistant from the opposing tibia, and the margin of femoral condyles and tibial petals are in alignment. We will see this in radiograph, I mean, the illustrative diagrams later. And this distal part of patella on the frontal projection especially should be at or above the level of intercondylar notch, which actually would rule out high or low lying patella. And on the frontal projection, there is a part of fibula which usually gets overlapped on the lateral margin. So there are multiple views and multiple variant views, but the most basic is frontal and lateral projection, which is assessed day in and day out. But there are views like horizontal, oblique, and skyline and tunnel views, which adds or helps to the more elaborate visualization of loose bodies or the patella. So this is what we are talking about in illustrative diagram, where you can see the condyles of tibia and femur. It has to be smooth, should be equidistant. You have the eminence, you have the notch, and you can see the superimposed patella, which is just at or above the supracondylar notch. And a part of the fibular head appears to be overlapped with the tibia. This again, as I was talking, we tend to get the ideal lateral view. Ideal lateral view would not see this, and we would be having the lateral and medial condyles of the tibia, the femur, being projected equally on each other, and the joint space usually appears clear. Here is slightly oblique, but that's the day in and day out practice, isn't it? I mean, we don't usually get textbook pictures of the knee joint. So this again depicts the horizontal beam radiograph, where you can see the infrapatellar tendon, the quadriceps, and the suprapatellar rhesus or suprapatellar fat stripe here. There are a few other views that we had added. So if you want to throw the condyles out of the frontal projection slightly laterally, or if you want to throw the patella outside the view of the frontal projection, we usually start with oblique internal external rotation, where the lateral tibial condyles will actually overlie the whole of the fibula, and the lateral margin of the patella is demonstrated, depends on which side you rotate. A tangential view of tibiofibular joint will also show the medial aspect of the patella. So here we have one example of the oblique projection, where you can see the patella being thrown out of the projection, and you can see the fibula being projected over the tibia rather than on the side, which we saw on a routine frontal projection. So this again a specialized view, where it's called a skyline view or sunrise view, or commonly called as axial view. So where you have the patient's, pardon with me my drawing, but I'm just giving a rough idea. So that's a patella, and the film is either here or here, and the beam passes right through here, and we have a varying degree of flexion depending on the requirement. We will see later in this talk, there are certain degrees that we use for certain aspects. So basically we can see the patella groove, the medial and lateral aspect of the facet. You can see the trochlea, And we can see the alignment as well here. So this basically is used for assessment of integrity of the bone, um, or it can also be used for the displacements and dysplasias. So when you need to know the intercondylar eminence or intercondylar notch, so we use a specialized view called a tunnel view, wherein various portions are used. Basically, it would be angling the beam right into the tunnel, where you can throw out all of the structures just to view the intercondylar eminence or notch. So here we can see usually the loose bodies or any avulsions that's happening in the eminence or the notch. Apart from this, the stress imaging, though there is no consensus over what kind of stress imaging can be used for assessing pre and post-operative, there are multiple studies being done, and we are not going to into much detail of this, but we can see a few examples where this can be helpful. One is the routine weight-bearing frontal projection, where you can assess the joint space and then alignment. The rest, another one which is used usually pre and post-op for assessment of the stability and alignment of knee is kneeling down weight-bearing views, where you can have a pad wherein the patient puts weight on the tibial tubercle, and then the rest of the thing goes, the pressure goes down, and that's imaging plate, and the beam passes from this way, from the screen into the screen to the opposite side of the screen. That's the image you would get. There are a few measurements, and it's again very variable, and there are multiple studies. But a common thing that's used is to get a posterior line on the posterior cortical surface of the tibia and draw a straight line. And then the intercondylar roof, which is joined here, the Blumenstadt line, the posteriormost aspect of the Blumenstadt line is taken as a reference. And the distance between this line and this point is measured. And varying studies are there, but a few common things are, I mean, I'm just showing you a few slides of prominent studies. But here you can see again, there is a distance between the posteriormost aspect of the Blumenstadt's line and the paralleling posterior cortical line is about 6.4 milli. This again is another stress radiograph where you can see depicting the posterior cortical line and the line which is posteriormost posteriormost point of the Blumenstadt's line. So there have been various studies in sense like, so the basic consensus that was taken out from is like in an uninjured knee, the variability of 4 mm up to 4 mm side to side difference seems to be normal. And if there is a symmetric posterior tibial displacement, which would indicate about indicate a PCL tear, PCL injury, and the permissible limit is about 5 to 12 milli. And if you have a contralateral knee difference about more than 12 mm, and you should also think about postlateral corner injury. This again is a variant where you can make the patient lie down with a flexion of 60 to 70 degrees, and you can manually give pressure over the tibia, as you can see the hand over here. Yeah, again, we in assessing the lateral and frontal projection radiographs, we have few quick checklists. First thing, we can access the intercondylar region, the neck and the head of the fibula, the tibial plateau, the eminence. It should be smooth, absolutely smooth, no steps, no irregularity, no lucencies, and the distance and the subcondylar bone appears absolutely homogeneous as compared to the rest of the bone. And if you drop a line which is paralleling the lateral or medial femoral condyle on each side and the tibial condyle, on each side. The distance, permissible distance between them is 5 mm. Anything more or less, we should be thinking about underlying either ligamentous injury or underlying fractures. And we will see some slides showing this example. And the patella, which is projected over here, I'm sorry, this part. Again, you can see it's below the intercondylar notch, so it's normally positioned. And we also look for any small bony fragments that can be appreciated on this frontal projection. Apart from this, when you're dealing with pediatric radiographs, and we have to be slightly more worried or concerned about epiphysis, the condylar surface and the cortex. In sense, you are more likely to find these appearances on the epiphysis, or this where you might, the cortical lines where you might have some subtle bumps, and which could represent a green stick fracture. On lateral projection, we again have similar views, where similar structures which has to be assessed. And this is in reference with the diagram that illustrated diagram we saw, where we have to assess the prefemoral suprapatellar area, the infrapatellar tendon, the quadriceps tendon, and the level at which it is there. The patella is oriented, the intercondylar Blumen's line, and the condyles. We can also appreciate fragments of bones or loose bodies, which should substantiate your diagnosis. And you can always see a different appearance of fluid or fluid flat level that can be appreciated in the suprapatellar region. So we will now go through few common pathologies which you would see on radiograph. Of course, the imaging trend has changed now, but on radiographs, which is slightly uncommon that we face it, because most of the time we see that it's been like a CT or MRI that we face, but radiograph actually plays a vital role, and it's a prime diagnostic modality that is available. And sometimes we tend to overlook as well. As you said, the prepatellar stripe, suprapatellar stripe, I'm sorry, and or prefemoral fat, this region, suprapatellar rhesus region, it can be seen appreciated here, which is looking abnormal, where there is significant amount of increased density over here, which could represent of blood, hematoma, and there is a significant soft tissue edema associated with it. This again is another, oops, I'm sorry. Yeah, again is another horizontal beam radiograph where you can see a special appearance where you would have layering density of content in the suprapatellar region, which could represent fat fluid level, usually hemarthrosis, fat fluid level here. And if you can appreciate better, there is significant edema, thickening, and subtle discontinuity of the cortex and representing intracranial fracture. Going further into ACL and PCL injuries, you would know the mechanism, and most of them again is dealt in MRI and CTs, but we would see the classification and few appearances that usually we encounter on radiographs. This could be avulsion or secondary changes in the bone or alignment. So this is a common thing, very subtle, but difficult to assess. Again, depends on the quality of radiograph and positioning. And we should also remember that the patient is in extreme pain when this has been done, and we can't organize or ask the patient to be in an ideal position, which is required. So that's why I told in the first few slides that it's difficult, but we usually can pick up these subtle findings. If you can observe here, the lateral femoral notch, it's an injury that can be assessed on the lateral radiograph. So you have a lateral femoral condyle, and then there is a depth, and then it goes back again. And this, when you draw a line paralleling to the normal cortex, this depth can be assessed. And when you compare with the normal individuals, a permissible limit of 1.5 mm is allowed, beyond which is regarded abnormal, and suspected ACL injury has to be ruled out. Here again is another example where you can see the suprapatellar stripe being slightly abnormal, where there is some fat level and there is thickening and edema of the tendon. Another fracture, avulsion fracture that is associated with internal derangement of knee is Sigon fracture, which is a part of lateral tibial condylar bone, which is this one, which appears to be paralleling the bone here. And it is associated with ACL injury, likely detachment of the capsular attachment of iliotibial band and the lateral capsular ligament, which is shown here, which has to be keenly differentiated from the femoral, the fibular head, where another type of fracture is again appreciated. So that one, the small flake, ever so small slight flake that appears to be associated with the fibular head, and it would represent the site of insertion of arcuate ligament, and posterolateral corner injury is suspected when you find this in a clinically appropriate setting. Here again, as we are discussing in first few slides, the alignment has to be noted. When you have a first look, there are multiple findings here. You would see the alignment way beyond permissible limit. You can see increased density over here. You can see the condyle is not smooth, it's stepped off, and there is irregularity. So it's actually representing, it would be associated with a medial collateral ligament injury as well, but there is underlying fracture in this patient with a deviation of the lateral alignment of the bones. Yeah, so 5 or 6 slides prior, we saw about the avulsion fractures related to ACL and PCL. Various classification again exist, and the extent and the treatment modality changes based on the classification. Of course, yes, it has been replaced by 3-dimensional imaging, but sometimes the orthopedicians, you should be appreciating that orthopedicians would take chance and would be having enough definitive signs to go ahead with planning. So you can see a flake of bone in the joint space. And then once you see the flake of bone, you should see the origin or donor body. And if you can see that there is a donor body associated with that, and in a clinically appropriate setting, this actually indicates attachment of ACL and ACL avulsion fracture. The classification is mild, where you don't see the avulsion completely, moderate, where there is slight anterior elevation of the fragment, and there is complete elevation, and complete elevation with the major eminence being involved, and fragmentation. I think this is the stop point for non-aggressive management, as non-surgical management, or if it is appropriately aligned, or when the reduction is successful. So beyond this would be mostly surgical treatment plan. So we'll see a few radiographs. So before that, yeah, the PCL also has a similar type of injury pattern and classification, where you have non-displaced, mildly upward displaced, and totally displaced fragment. It's type 3. You can see a flake of bone over here in the posterior aspect, which is actually projected over the eminence. So this represents mild to moderate PCL avulsion fracture. Here again, there is a small flake of bone, which appears to be grossly away from the donor body, or bone of origin. So it's actually displaced PCL fracture. These are another few examples of avulsion fracture with displaced fragment, where you see a rarified amorphous bony fragment over the posteromedial aspect of the knee joint space. And these avulsion fractures can also involve inferior pole of patella, where you can have small bony fragment. Again, in appropriate clinical setting, this would represent a tendon avulsion. Apart from this, as I said, when you have some loose bodies in the joint space, we have to look for uh, evaluate the surface integrity of the bony surfaces that's at least visible. Of course, the articular cartilage well extends till the posterior surface, and you can have an osteochondral fracture fragment which has been dislodged, but I'm not going into that. At least where if you see a bony flake here, for example, in this case, I don't see any condylar irregularity. So most likely it would represent osteochondral fracture with dislodged fragment that's from the patella. And here again, you can see a gross hematoma and edema. In this scenario, we can see a small osteochondral fracture with lucency beyond it, which is actually indicating a high-grade osteochondral fracture. And here as well, there is a small osteochondral fracture fragment noted here. Unfortunately, we can't see the chondral cartilage on radiographs, which has to be where you can have chondral injuries without bony fragment, which can well be picked up on MRI and CT. Yeah, so we'll go ahead with dislocations where you can have patellar, tibiofemoral. We're not going to deal much about tibiofemoral and tibiofibular. We are going to deal with patellar, and the next slides will be with patellar dysplasias. So most common is lateral, and it can be transient and can be associated with osteochondral injury. We saw few slides prior, which actually represented lateral patellar, transient patellar dislocation with osteochondral fragment. Here again, the expected place for patella is over here. As I said, should be inferior pole should be projected over here, and you would not be able to see the lateral or medial margin of the patella. Yes, you might say that, oh, it is not, is it oblique? Yeah, it is slightly oblique, but still you can see the fibular head, which has been projected laterally over the thing. And yeah, joint space is not preserved, possibly indicating underlying further ligamentous injury. But as I said, the patient is in extreme pain mostly, and you would not expect them to come and put an anatomical position for your imaging. So few other patellar conditions include thickening, diffuse thickening. You'll not be able to see much appreciated well on the radiograph, but you can sometimes see, and bony fragments which are associated with thickened tendon, which would represent patellar tendinopathy. Here again, you can see the diffuse thickening and fragmentation of the bony structures attached to it. And there are few other conditions like Osgood-Schaltz disease, where there is a constant extraction of force transmitted over the tibial tuberosity. As a result, it becomes fragmented into small osseous segments. Or this can occur in the other side, where there is a traction on the inferior pole of patella. It's called Sindring-Larsen-Johnson syndrome, where there is a repeated traction of patella over the inferior pole, resulting in small fragmentation. This can also sometimes be presented as a small beaking of the inferior patella. Yeah, this is a gross anterior and posterior tibiofemoral dislocation, where it would indicate a high-grade internal derangement of knee with multiple ligamentous and bony structure abnormalities. So last but not the least will be patellofemoral dysplasia, and then we'll see a few slides on post-operative imaging. So it can be a trochlear dysplasia or a patellar tilt or quadriceps dysplasia, or it can be high-lying patella, or it can be a discrepancy between the tibial tuberosity and tibial group distance. So more consistent were seen in the first two. And again, I would like to say that this is most likely been replaced by volume rendered three-dimensional imaging, but we have significant imaging based on measurements based on plane radiographs as well. So there are a few structures that you need to know. The medial, I'll just go ahead with another slide. Yeah, before that. So we have a lateral condylar surface. You have intercondylar notch surface where the roof of the intercondylar notch, it would usually not meet. So the few signs that we usually describe in when you see on the proper lateral radiographs, where you can see now, yeah, this is a near ideal radiograph where you can see the finely aligned patellofemoral joint space, just slightly incongruent condyles, where you can see a double contour, which I would explain in a few slides more. And there is a crossing over sign over here, and there is a beak. This all would represent distal femoral dysplastic signs. And this is what I was talking about, the axial imaging, where you can see the patella and the trochlear surface. You can appreciate well that there is dysplasia in the medial and lateral facet, as well as the trochlear surface with abnormal trochlear angle. So the signs which we saw 2 slides prior is being described here, where you can see the meeting point. I mean, it should not meet, it should ideally go like this. And if these two meets, actually it will denote, it's a true lateral radiograph. So actually denote there is a shallow trochlear groove. So another sign is crossing over sign, where when you have a flattened trochlear groove, the spur is appreciated when you can have a flattened, instead of a shallow trochlear groove, you will have a flattened trochlear groove, where you can see a beaking, small beak over here at the level of patellofemoral joint. And you have a double contour sign where there is a discrepancy in the condylar size, the medial condyle and the lateral condyle. In fact, usually the medial condyle is slightly larger. Here, the medial condyle becomes shallow and small. So the lateral and medial condyle appears to intersect, and it gives a double contour. And you see again the crossing sign here, where the condylar roof actually meets the lateral condylar surface. This one describes all the 3 signs, where you have a crossing over, you have a double contour, and you have a small cliff, which is denoted on the true lateral radiograph. When the beam passes, actually, these are the images when the beam passes from the lateral and hits it. And you have a projection, because it's radiograph is projection imaging, you cannot appreciate the cliff here. These are representative images from CTs or MRIs. So this imaging actually by one of the classification denotes the increasing level of dysplasia, increasing grade of dysplasia, as described by one of the authors. Here again, you can see on the radiograph, where you can see the crossing over sign, where it meets the trochlear roof, actually intercondylar roof meets the lateral trochlear margin here. And here again, you can see the crossing over sign and the double contour sign, where you can see the medial and lateral condylar surface being projected over the medial condylar surface being projected over the lateral condyle. The position of patella can be assessed on the true lateral radiograph as well. Here again, there is an obliquity in the lateral radiograph. I was been talking in first few slides and many other slides. The positioning of radiograph becomes very, very important when the patient is not in pain. Here you can see 2 indexes named as Insall-Salvati index ratio or modified ratio, where one is actually measuring the superior to inferior pole, one actually measures the articular surface, and the other ratio is the length between the inferior pole and the attachment of the tibial tuberosity, and this is from here to here. The first one, without, the normal routine Insall-Salvati ratio is 0.8 to 1.2, and the modified index is up to 2 is considered normal. Beyond it is considered patella alta or baja, depending on whether it is more than 1.2 or less than 0.8. When there was axial radiograph that I have been describing about, it depends on varying degree of flexion, the image can be obtained. So this flexion area is important and the degree is important. And the problem here comes with the repetitive ability to reproduce this in various settings. So you should have a standardized setting. So because we don't have much of consensus, this actually is very variable. So this is one of those Merchants and Lawrence view where we can actually see the lateral patellofemoral angle. You can see the angle, normal angle between the lateral facet and the intercondylar line is about 8 degrees, beyond which is abnormal. That means actually it's more and more acute. So that means this patella is actually lifted up, and so there is an opening of medial aspect, opening of the medial, and this nearly parallels the surface. And you can grossly see that there is the displacement about the dislocation and displacement of the lateral patellar margin here. This again are two radiographs which depicts the level. This is what I was talking about. The inferior pole should be roughly, without even measurement, the inferior pole should be roughly beyond this line, and both of this line is actually above the lines. So actually it's high-lying patellas in both of them. So again, one slide, a few images on degenerative changes which also can occur and which will also result in severe derangement of the knee with multiple ligamentous weakening. So this is actually a weight-bearing view where you can see multiple osseous extrusions, severe sclerosis, joint space narrowing, and there is a bit of medial tilt, which all would indicate a severe degenerative process. There is in fact calcification of underlying menisci here. Again, the skyline view or the sunrise view or axial view, where you can see osteophyte formation, severe osteophyte formation on either side, severe joint space narrowing. In fact, it is mean approximated, and possibly there is a degenerative dislocation where you can see the patella being laterally displaced. Here again, another view where you can see changes in the menisci as calcification and osseous bumps. So reconstruction radiographs after post PCL and ACL are essential in evaluation of pre and post operative imaging for optimal assessment. So few things has to be dealt with. You have to deal with the femoral tunnel, which is the appearance of femoral tunnel, the position of femoral tunnel, appearance and position of tibial tunnel, and the hardware. So as a rule of thumb, based on varying degree of abnormality, on the frontal projection, the femoral tunnel should either be at 11 o'clock or 10 o'clock on the right, and then 1 or 2 o'clock on the left knee. So this actually represents the femoral condyle, distal femur, and either it should be between this or this. The tibial tunnel on the AP, the frontal projection, usually comes out at the eminence. On the lateral projection, it will be just posterior to the Blumensaatz line. At the level or posterior to the Blumensaatz line. So which we'll see in few other radiographs now. And the canal depth is usually assessed and to be abnormal when the width of the canal is more than 2 mm in the immediate preoperative stage. And the hardware can be assessed by knowing whether the hardware's position is normal or abnormal on the radiographs. So this again, another measuring lines where you can see the posterior cortical line here, and you have the intercondylar Blumensaatz line here. The position of the inferior femoral tunnel should be located at this level or slightly anterior to it. So here again, you can see the femoral tunnel, tibial tunnel, which appears to be slightly at or anterior to the posterior to the Blumensaatz line. This again shows the abnormal position. The tunnel was initially here. Probably it's migrated down here. It's abnormal position femoral tunnel. This radiograph again depicts the position and alignment of the tunnels, where you can see the tunnel here, which appears to be at the level of intersection of the posterior cortical line and Blumensaatz line. And here the femoral tunnel, tibial tunnel appears to be posterior to the Blumensaatz line. Here again, the imaging is slightly oblique, so it looks more pronounced and posterior to the Blumen's slides on the TBS. So that again depicts the tibial tunnel, where on the lateral radiograph it's posterior to this, but when you see in the frontal projection appears to emanate at the eminence. So there you go. You can see that appears to emanate at the eminence. And here again, you have an endo button over here. Depending on the side, either it should be here or it should be here. And the tibial tunnel appears to emanate at the medial eminence. This is again to pick up another commonly occurring complications of post-reconstructive surgery. You can see a small loose body that is being formed here, and which would limit the range of motion and cause pain to the patient. Here, this is another complication where you can see the femoral hardware appears to have migrated, and there is a medial migration of, it should be like this, instead of there's a medial migration of the tibial screw as well. This is how you can see it on the frontal projection, where actually it sees as it's seen as if it's projected over the femur, but again, one view is no view. That's what is dictum. So the next view shows that it's been projected outside. And this is a depictive diagram for placement of the usual ideal placement of the tibial and femoral tunnel on a PCL reconstruction, where ideally you will see PCL tunnel, I mean the tibial tunnel about 6 to 8 centimeters from the joint line, directing posteriorly, and it's just 5 to 6 mm above the hourglass appearing drop-off point of the PCL attachment. And there is a small endoper in place, or the screw where it is supposed to have the femoral attachment. Usually it's single band sometimes, but ideally my colleagues will agree the double band reconstruction is more appropriate. Here again, a depictive diagram again showing the site of tibial and femoral placement of tunnels in a PCL reconstruction. Yeah, that ends talk. Thank you. Sorry, went a bit longer, I guess.
Everything wonderful. It was a very extensive presentation. I think you can stop sharing the screen.
Okay.
You can exit. Yeah. Okay. So thank you, Dr. Anand. It was a very extensive presentation. You have covered all simple and also the more important and slightly more difficult to understand topics. I have a couple of questions. You were talking about the lateral femoral knot sign in the horizontal beam projection, right?
Yeah.
So you were saying that if it is more than 1.5 mm, you are suspecting possibly ACL injury. I mean, can you tell me the significance of the lateral femoral knot sign again?
The lateral notch is usually seen on a normal radiograph as well, but in a clinical setting, that's what I said, in appropriate clinical setting, where if you could measure it in an appropriate radiograph, properly visualized radiograph, it's abnormal. And it's not about the depth as well. It should also deal with the, okay, I'm not sharing the screen, isn't it? So I was drawing. No, I think probably the bone underneath and the smoothness of the notch, which is also to be emphasized.
Yeah, okay. So, I mean, when exactly is it affected? I'm not able to catch that.
So can I draw now? No, I can't draw now.
You can go ahead. You can share the screen if you want.
Share your screen. Okay, I can share again and I can draw.
Yeah. Please.
One moment, please. How do you share it? So I have to go again to the meeting?
No, actually, your screen is being shared. You can just go to your specific slide.
Yeah, for example here, yeah, that's a normal appearing notch. Yeah, normal appearing notch, slightly going inside. And where were we? Yeah. So what I was intending to say is when if you can measure the distance between this line and this depth, and here you can appreciate that in the smoothness of the notch is actually lost. I don't know whether you can appreciate, looks like irregular, and the bone underneath looks slightly sclerotic as well. It's not
Yeah.
as good as you can see here. So that scenario we are looking in terms of an inappropriate setting where you are suspecting injury and we are looking at not sign.
Okay. And is it also possible with the dysplasia?
Sorry, I didn't get you.
Is this sign also possible with the dysplasia of the femur?
I'm not aware of it, but I'm not sure it has been documented in dysplasia of the femur where you can see the knot sign.
Okay. Okay. Fine.
It's not.
Sorry, sir, Dr. Srinivas.
I'm not sure. I don't think in dysplasia we are not sure whether we see that.
Agreed.
And you were talking about the measurement of tibial subluxation in the horizontal beam projection again. You're saying like the cortical line should not be behind or in front of the posterior aspect of the Blumensack line. Does it also hold in, I mean, you were showing an image at 90 degrees of flexion. Does it also hold in, full extension?
I didn't get you. Does it also hold in full extension? No, the studies
in extension also in 0 degrees of.
the studies that has been done had been done at 90-degree flexion, or at least I think some of the studies had been done with 70-degree flexion with manual pressure. I'm not aware that it's been can be used in complete extension.
Okay. And your point about the arcuate sign for the proximal fibula, that's a very, very interesting one. It's a good one. It helps you to differentiate between a possible second fracture, which doesn't actually look like an arc, but in the proximal fibula, it looks like an arc. So it's a very beautiful sign that you pointed out. Yeah, and there's always a confusion of whether the second fracture depicts a lateral collateral ligament injury or an anterolateral ligament injury. Now we need, as you said, I would like to point it out again, it can be either or both, right?
Yeah.
So depending on where exactly the fragment is, unfortunately, we are not exactly able to identify exactly where is the injury in an X-ray. Possibly an MRI will be a better investigation to point out whether it's a lateral collateral involvement or an anterolateral ligament involvement. But we should also keep in our mind that an ALL involvement is possible, right?
Agreed.
Yeah.
The lateral collateral is more attached to the fibular head. So I think a second is more thought to be associated with anterolateral ligament injury. And I think there's something called the reverse second as well.
Yeah.
That's on the medial side. It's a capsular avulsion from the medial side of it.
Medial side. True.
Yeah, I would agree to what Dr. Srinivas said. That is, the majority of the lateral collateral ligament is attached to the fibula. So if there is a force that has to pull the lateral collateral ligament away from the bone, it's most possibly going to happen from the fibula. And if there is something that is coming up from the tibia, possibly because of the size of the anterolateral, that is the iliotibial band, it is possibly the anterolateral ligament that is pulled out. Okay, that's a very good discussion. And the X-ray depiction of ACL avulsion, that is also important. We need to identify between an undisplaced ACL avulsion or PCL avulsion and a tilted or a displaced ACL or PCL avulsion in order to make a decision regarding the surgery is required or not.
Very true.
Yeah. Okay. Srinivas, do you have anything else?
Couple of questions and a couple of comments actually. Can you give indications for horizontal beam lateral view?
Horizontal beam lateral view. Yeah, usually in trauma
Yes.
settings we use it. So in order to access the suprapatellar region. So it's a common place where we can access the hemarthrosis.
Yeah, especially when the patient is not able to weight bear.
Sorry?
It shows a fluid level on horizontal beam view.
Exactly.
And what are the common things that can be missed on an X-ray, on a knee X-ray? What do you think?
Obviously, the ligaments, any soft tissue components is going to be missed. Chondral pathologies are missed. On the as long as you don't have an osteal component with it, you can't access the chondral component.
Yeah, avulsions isn't the PCL, avulsions like a PCL is quite commonly missed. Patellar sleeve avulsions, and just a comment regarding you showed the dysplasia of patella. That classification is by Deju's classification. And can you go into the measurements, post-op ACL reconstruction slide? There's a very good paper for the orthopedic surgeons by Pinchevsky from Australia, giving where exactly you place the tunnels on the tibial side and the femoral side.
Okay. Post-op, you want the ACL. Yeah. Yes, please.
Yeah, the placement of the tunnel. They draw two lines. For the tibial side, there's a subchondral line. Medial to lateral. And the tunnel should be around 47% side. On the femoral side in the AP view, if you draw a line from the most prominent one points, it's about 43%. And the slope of the graft is supposed to be around 19 degrees, it seems.
With the intercondylar line. With the intercondylar line.
You draw perpendicular to the tibial line,
okay.
And then measure the tunnel, one line through the tunnel, one line perpendicular to the tibial line. The slope will be 19 degrees. And on the lateral view, the femoral is about 86% posterior. If you draw a line along the Blumenstadt line, it's at 86%. And subchondral line for the tibial side, it's about 46%.
That's very informative.
That's a rough guideline.
Okay.
And a word about bipartite patella.
I didn't want to go with the variants actually, bipartite patella and the fibullas and Pellegrini stata lesions. I didn't want, it was actually going, the talk itself was going beyond. So I just didn't want to add slides on normal variants that you should be aware of on the knee joint.
And do you use Rosenberg's views?
Yeah, we can. Yeah, that would really help in. Yeah.
Okay. So that's a wonderful presentation. Thank you very much, Dr. Anand. It was, I mean, it covered all the normal, abnormal, and also the post-operative radiological findings that we need to look for. Thank you very much for taking your time.
Thanks
I hope we see you in some other presentation soon.
Thanks for inviting. Thank you so much.
Yeah.
Thank you.
Thank you.
It was a nice presentation.